And now I'd like to introduce today's SAICEP webinar, Strategies to Address HPV-Related Cancers Among American Indians in Southeastern North Carolina, with Dr. Ronny Bell and Dr. Megan Huchko. Dr. Bell's professional biography can be read in detail here and is available in today's handout. But I would like to provide some professional highlights. Ronny Bell is an enrolled member of the Lumbee tribe, and in much of his research focuses on health disparities among American Indians. Dr. Bell is a graduate of UNC Chapel Hill and was in the freshman class with Michael Jordan. He is editor-in-chief of the North Carolina Medical Journal. He co-chaired the Healthy North Carolina 2030 Task Force, and he is a member of the North Carolina Minority Health Task Force. Dr. Huchko's professional biography can be read in detail here and is available in today's handout, but I would like to provide some professional highlights. Megan Huchko is an OBGYN who completed fellowship training in reproductive infectious disease. Dr. Huchko has been working on cervical cancer prevention in East Africa for 18 years. She helped write the ASCCP guidelines for cervical cancer screening. She is the medical director of the Cervix Clinic at Duke, and she is the director of the Center for Global Reproductive Health at Duke. Before we get started, we invite everyone to try out the Poll Everywhere application with a sample question. Please take a minute now to join at pollev.com/UNCLCN or text UNCLCN to 22333. And I'll give everyone a second to get that pulled up now. To practice using this, our first question is it true or false that the Southeastern American Indian Cancer Health Equity Partnership is a collaboration between the COE offices of Wake Forest, UNC, and Duke? And I'd like to take this time now to please write down your questions as we go to save for the end of the webinar. Okay, now I'm going to hand off to Dr. Bell and Dr. Huchko and let them get started. Thank you.
Thank you, Natalie, and thank you all for joining us today. I want to take a moment to acknowledge that November is American Indian Heritage Month, so appreciate the opportunities to bring attention to issues around American Indian health during this time of year. And so you've already heard about us and would love to have the opportunity to engage with you all going forward. So we'll start out with a poll everywhere question. So what is the largest American Indian tribe in North Carolina? You want to take a minute to answer that question? If somebody could give me a signal when I need to.
All right.
Okay. So most people got this right. So the Lumbee tribe is the largest tribe in North Carolina, and actually today is a very important day for the Lumbee tribe. There are Senate hearings going on now, well, this afternoon at 2:30, designed to have discussions around full federal recognition for the Lumbee tribe. The Eastern Band Cherokee is the only one of the 8 tribes in North Carolina that is federally recognized, but hopefully that will change after some of the efforts today. So SAICEP, and for those of you who have been a part of the SAICEP webinar series, which we do 3 times a year, thank you for joining us. If this is your first time joining, I thought it would be instructive to let you know a little bit about SAICEP. So SAICEP started in 2021 as a collaboration with the offices of the Community Outreach and Engagement at the 3 comprehensive cancer centers in North Carolina at UNC, Duke, and Wake Forest. And I was actually at Wake Forest at the time that we started SAICEP. And so SAICEP, our mission is to understand and address the cancer-related health needs of American Indian communities in our catchment areas and beyond. And if you want to take the opportunity and go to the UNCLCN website, and you can see all of our enduring lectures that we've done as a part of this series, you would definitely have the opportunity to do that and learn more about SAICEP. This is the current leadership of SAICEP, which includes the 3 Associate Directors of Community Outreach and Engagement at the Cancer Centers, Dr. Nadine Barrett at Atrium Health Wake Forest Baptist, Dr. Tamara Watts at the Duke Cancer Institute, and Dr. Stephanie Wheeler here at UNC Lineberger, and then myself as the Deputy Associate Director for COE here at Lineberger. So our goals are that we started out from the beginning to increase awareness of the cancer health needs of American Indian populations, primarily here in North Carolina, to expand access to cancer health education and build community capacity to address cancer health needs, and to develop collaborative research and community relationships, which you'll hear about today, to better understand and address the cancer burden of American Indian communities. So we had a couple of publications recently, and I would be happy to share those with you if you're interested. But we have been able to, using the CIPHER database here at Lineberger, we've been able to identify some of the 5 most common cancers among American Indians in North Carolina that you can see here. We've also noted some significant disparities, particularly in liver and stomach cancer incidence, in prostate, liver, and stomach cancer mortality. Also noting that American Indians are more likely to be diagnosed with and die from cancer at a younger age, and also to receive poor quality of care at the end of life. And this research was led by Dr. Lisa Spies, who's in the School of Pharmacy, and Dr. Mark Emerson, who is a member of the Navajo tribe and a professor in the Gilling School of Global Public Health. We've also, in the process of trying to learn more about the cancer health needs of our tribal communities, we've done, as a part of SAICEP, a number of talking circles, which is a culturally based way of expression that occurs in tribal communities. And so we've been able to partner with 3 of our tribal communities, the Lumbee, the Coharie, and the Halawassaponi, to, again, get a better sense of what are the cancer health needs in these tribal communities. And we've been able to then take that information and create these beautiful infographics that we were able to share with the tribal leadership. And so that's been a really great experience for us, and being able to learn from our tribal communities, but also share with them how we might best engage with them in this process. And we've also, through funding from the V Foundation, we have just recently launched a young adult cancer health ambassador program focused on three specific cancer risk factor areas that primarily affect youth and young adults. So sun exposure protection, HPV vaccination, which is the focus of this session today, and harmful tobacco prevention and cessation. And so we have 12 American Indian high school students who are participating currently in training for this health ambassador program. So I'm going to turn it over to Dr. Huchko at this point.
Great, thank you. That was a great introduction. And today, both Dr. Bell and I are going to be talking about cervical cancer, even though it wasn't on the list of the top 5 cancers in North Carolina or among Indian populations in North Carolina. But I want to start by asking how many women worldwide die from cervical cancer every year? Okay, so most people got that right. It's around 350,000 women will die from cervical cancer every year. It's a bit more than the number of women who die from pregnancy-related causes. And yet in the OBGYN world, we often don't hear about cervical cancer as much. And we're really focused on prevention. About 600,000 women will be diagnosed with cervical cancer every year. And women who are diagnosed will have to, navigate the process of finding and experiencing treatment. And most of the women who are diagnosed with cervical cancer are diagnosed in areas where there isn't great access to treatment. So it represents about 3% of cancers and cancer-related deaths worldwide. And again, these are the numbers I just gave. The incidence and mortality align with the Human Development Index, with most of the cases and deaths occurring in low and middle income countries. And you can see that represented here in this world map. This is an incidence map from 2022, where the countries represented in the darker blue have higher incidence of cervical cancer. If we were to put a mortality map up, it would look quite similar. And so if you look at maps like this, it could look like, why are we paying attention to this in the United States? And that's one of the things that I wanted to talk about, because when we see aggregate data like this, it can sometimes mask challenges within our own countries or in our own states and communities. In 2018, Dr. Tedros, who's the Secretary General of the WHO, made a call towards the elimination of cervical cancer. And in that call, which was unprecedented for something that is a cancer and not an infectious disease, he said that cervical cancer is one of the most preventable and treatable forms of cancer. Both prevention and treatment are highly cost effective. However, it remains one of the greatest threats to women's lives, and globally, 1 woman dies of cervical cancer every 2 minutes. The suffering is unacceptable and cannot continue. So even though we saw the United States in light blue, and we saw that it's not one of the most common cancers in North Carolina, I think the key to cervical cancer is that it is preventable. And just to make sure we're all on the same page with that, it is a very unique, it's a somewhat unique cancer in that it is associated with infection with HPV. So this is a map, a schematic, and I promise it's the only biology we'll see in this talk, but this is the surface of the cervix. And you can see here that these blue cells are normal, and there's a transition period after infection with HPV, which is here underinitiated, where the cells can become mildly abnormal, which are represented in purple, and then more abnormal, which is represented in red. The important things to note here in this graphic are that the arrows up here at the top go both ways. So the body can clear HPV, and the body can even clear some of these abnormal cells. The other important thing to note is that these cells can be picked up early on before they pass through what we call this pink line at the bottom, the basement membrane. So there are opportunities to prevent cervical cancer. There's primary prevention, which would be done with the vaccine. And we have a very effective vaccine that can prevent up to 90% of cervical cancers. And then secondary prevention, but primary prevention of cancer would be treatment of this detectable or precancerous stage that you see in the middle. So with these really effective prevention methods, we can essentially eliminate the risk of most cervical cancers in the world. And so on a global scale, the WHO, along with program planners and academics around the world, have set out targets for how elimination could be reached. So their overall goal aligns with the Sustainable Development Goals, which are the WHO's and United Nations goals that were set for 2015 and now for 2030. So to align with that, they're seeking a 30% reduction in mortality from cervical cancer by 2030, which is coming up quickly. But then to reach elimination within the next century, they've set out these targets to achieve 90% of girls being fully vaccinated in adolescence, 70% of women getting screened once or twice in their lifetimes, and 90% of women who have invasive cancer to get treated. And they've defined elimination as less than 4 cases per 100,000 women. So I mentioned, or it was mentioned, that I work in East Africa, where the incidence is, between 40 or 70 per 100,000. In the United States, it's a lot less, but the goal across the world is for people to work with countries, systems, and programs to work within their resources to reach that last part, to move from whatever their current incidence is to less than 4 cases per 100,000 women. And the things that are driving that is this increasing disparity. So cervical cancer is preventable. We have effective and cost-effective prevention technologies, but we're seeing this increasing disparity. The other reasons are that we've seen programs that have modeled simplified prevention strategies, which include the HPV vaccine and lower cost, lower tech methods for screening and treatment. We've seen studies where they can be implemented successfully and effectively in lower income settings. So to think about the United States and where we stand, rates in the United States are about 7.7 cases of cervical cancer and 2.2 deaths per 100,000 women years. That translates into approximately 13,000 cervical cancer cases per year. And we've really seen a marked decrease since the advent of colposcopy, which is examination of the cervix after application of some acetic acid, which we still do. But colposcopy now is driven by cytology or pap smears. So both of those were introduced in the 40s and 50s, but the pap smear has really revolutionized cervical cancer prevention. So with a simple smear, the pathologist or the cytopathologist can look at cells, and that long precancerous stage can be detected. And then there are several simple forms of treatment which are very effective. So since that screening with the pap smear is very effective, we have seen that half of the cervical cancer cases in the United States are occurring in women who don't have access to screening. So they're either unscreened, and the majority of the women who are unscreened are immigrants from other countries, or they're underscreened, meaning they've had screening, but they haven't had the appropriate follow-up. So here you can see this nice graph of this decrease in the rates of cancer diagnosis in the United States, and then in the 2006 and in 2012, the ACIP recommended the HPV vaccine for girls and boys. So we have not seen any impact of that yet because cervical cancer occurs in the mid 30s, and later in life. So the people who have started to get the vaccine, we're just going to start to see the benefits of that. And I think, as Dr. Bell will talk about, we haven't achieved the rates of vaccine in this country that will really be driving us to elimination. So we really still need screening to impact the women now who are aged out or too old to get the vaccine, and really to make up the difference because we have not achieved vaccine levels as that would be effective to reach elimination. So as I mentioned when we saw the worldwide map, that light blue or low incidence in the United States should be looked at a little bit more closely, and you can divide up using the SEER database. You can divide up rates of cervical cancer and cervical cancer mortality by various characteristics. So this map of the U.S. just shows that the incidence of cervical cancer is not shared equally across the country. So for all races, we can see that in the South, they have higher incidences of cervical cancer. And then if you look at rates across different races, we know that incidence and mortality rates are higher among non-Hispanic Blacks and American Indians and Asian Pacific Islanders. Those are the ethnic groups that the SEER databases use. So you can see here in the states where they're on the left-hand side, in the states where they're reporting by race, that Black women have higher rates of cervical cancer in some in the South, some in the Northern Plains. That's not something that we're seeing markedly in the South. Just to note, when we look at these maps, the age adjusted incidence rates change. So you might see something in light blue on one, and the actual numbers are different in one graph from the other. So while you're reading those, a little caveat. And then on the lower right-hand side, in countries or in states that have this data, they've presented incidence rates by among American Indians. So in North Carolina, we have a lower rate compared to other states that report this, but the rate of cervical cancer among American Indians in North Carolina is about 10.2. And remember, that's compared to overall rate of 7 for all populations. So you can see up in the Northern Plains states, they have higher rates, but we're sort of right in the middle of that reporting. Within North Carolina, this is statewide data. So by health service area, across all races. So this is not specific to American Indians, but you can see that the highest incidence rates in North Carolina are in the highest incidence rate is in Robeson County in the South, and that's about 9.1 to 10. So American Indians in North Carolina convey the highest incidence rate of cervical cancer. So they are clearly, there's some disparity in the way that these prevention technologies are reaching women in these counties with higher rates. And we know that among American Indians in North Carolina, the rates are higher. So today we're going to talk about how we can understand some of the driving factors in continued disparities in cervical cancer rates here in North Carolina among American Indians. And so thinking about the prevention technologies, what are the barriers that are faced to HPV vaccination, to screening, and to the necessary follow-up care? And so, thinking about individual barriers, beliefs, knowledge, behavior, interpersonal, what is the relationship with the provider? What's the provider's understanding of someone's risk or need for screening? What are the systems level barriers? And then how could we take those barriers and turn them around and really, understand motivating factors to increase cervical cancer prevention and engagement? And how could we combine those two things and develop implementation strategies that really fit the needs of women in the Lumbee tribe. And so with that, I'll turn it back over to Dr. Bell.
Thank you. So one of the things that we wanted to try to do in our efforts to better understand cancer risk and availability of cancer care and cancer prevention resources in tribal communities is to look specifically at HPV vaccination. Nationally, when we look at data for American Indians and meeting the criteria for adherence to HPV vaccination among those that are eligible, the data seem to indicate that American Indians have very similar rates to non-Hispanic white youth as far as meeting those criteria. The challenge we have is that the national data oftentimes only reflects data or populations that are what we call federally recognized, which is what I referred to at the beginning of the presentation. And so that federal recognition goes along with having access to healthcare resources through the Indian Health Service, either directly provided by Indian Health Service or funds are provided for a tribe to set up their own healthcare system. And so, and there's also, straightforward protocols for HPV vaccination among tribal members when there is an IHS facility in a tribal community. What the data doesn't show is what this looks like when a population with a tribal community doesn't have access to Indian Health Services healthcare resources. And also we know that many of the tribes across the country are in areas where there are adverse social determinants of health. The Lumbee tribe in Rapa, which is primarily based in Robeson County. Robeson County, we know, is of the 100 counties in North Carolina, has the worst health outcomes, and a lot of that is driven by adverse social determinants of health. It's also, it's a rural community, and so we know that access to care in rural communities is particularly challenging. So that sort of leaves this gap in our understanding in this particular area. And so wanted to throw out another question here. So what is the Healthy People 2030 goal for HPV vaccination for adolescents in the U.S.? Is it 50%, 60%, or 80%? So it looks like most people got this right. So the recommendation is that we increase the proportion of adolescents who get the recommended doses of HPV vaccination, and HPV vaccination is a multi-stage process. So this would be the recommendation for getting the full dosage of the vaccine. And so you see that the most recent data in 2021 is about 58.5%, and the goal then is by 2030 to increase that number to 80%. So even we know that even though the data nationally that we have available to us shows pretty similar rates for American Indians and non-Hispanic whites, we do know that both of those rates are well below the Healthy People 2030 goal of 80%. And so with that in mind, we applied for and received a small pilot grant from UNC Rural in 2024. And we were able to look at our goals for this project were to try to understand the the barriers of facilitators to HPV vaccination among Lumbee Indian adolescents and their parents. And these are photos here of two of my colleagues, Brianna Yarborough on the left, who is a student in the pharmacy school here in the PharmD program. And then over to the right, Dr. Nadia Violette is a faculty member in family medicine and public health. And she actually has just recently received the K Award to look at HPV vaccination disparities in rural parts of the state. And so we actually have the ability to combine the efforts of our pilot grant with the work that Dr. Violette is doing for her K01. And so we had two aims. One is to identify barriers or facilitators among the parents of Lumbee youth through in-depth interviews. And you can see our eligibility criteria. So they had to be self-identified as Lumbee, have an age-eligible child between the ages of 9 and 17 years, and to be enrolled as a patient in Children's Health of Carolina, which is a large pediatric practice in southeastern North Carolina that sees a large number of Lumbee children. And so we have been doing, we're still in the process of doing one-on-one interviews with these parents. And then the other part of our project is to interview healthcare providers within the CHC system to ask their thoughts about the barriers or perceptions of ensuring that their patients are adhering to HPV vaccination. So we report here some preliminary findings from our project. So we were able to do two focus groups with a total of 13 providers at two of the clinics in the CHC network. And I just want to take a second to acknowledge that my brother, Dr. Joey Bell, who is the first American Indian pediatrician in North Carolina, he was the medical director at one of these two clinics, and unfortunately he passed away in June. But we were able to do these interviews with the providers. They were very gracious to allow us to come to their clinics and do these interviews. And so basically what we learned in this process is that anytime they said they generally don't see a lot of hesitancy around vaccines in general. So we created a focus group guide for these interactions with the providers. And so we ask about vaccines in general, then specifically ask about HPV. And so they indicated, that there's some degree of hesitancy, particularly around since the COVID pandemic, and that the sort of general decrease in trust in the government has sort of led to that. They did mention that a lot of parents had challenges in trying to get to the clinics, and so oftentimes they tried to combine HPV vaccination with either with a well child visit or some other way in which some other opportunity they had to engage with the parent and the patient. And so they did say that when they talked to the parents about the importance of HPV vaccination, and also specifically looking at how cancer, specifically cervical cancer, impacts their community, there was a lot of receptivity to having their child vaccinated. We've only done 3 parent interviews so far, but basically what we have seen very consistently is that parents, they do have a very high level of trust in their providers when it comes to recommendations for vaccines, with the exception of the COVID vaccine. We saw, even though it's a small number, we did see a fairly consistent message that parents were not particularly trustworthy, not necessarily trustworthy of the providers, but trustworthy in general that the COVID vaccines were safe for their children. I'll turn it back over to Dr. Huchko.
Great, thank you. And it's exciting to have some findings because we're just at the start of our study, but to add on to the prevention toolkit, we're looking at developing a roadmap for implementation of home-based HPV screening among members of the Lumbee tribe of North Carolina. So why are we talking about home-based HPV testing? Right now, cervical cancer screening can require multiple visits, and home-based HPV testing is not the current standard of care. So if someone goes into their primary care provider or their gynecologist, they can get offered screening with either primary HPV screening or co-test, which is a pap smear read first and then HPV screening. All of those now require a pelvic exam and a clinician to collect the specimen, which can be uncomfortable. And for people who have had trauma or for transgender men, these can be really traumatic and avoidant exams. If that comes back positive, there is, for the provider, a web-based or a phone-based app to guide on the next steps, because there are about 25 different answers that one could get from that primary test. And they offer to bring the woman back in for a biopsy. Many places don't have the capacity to do a biopsy along with a colposcopy. So the patient may have to navigate a new setting, meet a new set of providers. There may be unexpected or anticipated costs for the patient, as well as travel, understanding, getting time off work, getting childcare. And then as complex as it is for the provider to understand the various algorithms to ensure the right follow-up and treatment strategy, the woman herself has to understand what the results mean and whether she follows up in 6 months, in a year, in 3 years, in 5 years. So it can be really complicated. And one of the things that could potentially simplify that is starting with HPV testing. That doesn't change the need for the pelvic exam or the biopsy, but it might simplify some of the results and decrease the number of women that move to the next step of colposcopy and lengthen the time between screenings. The other real potential of primary HPV testing is that HPV testing can be offered via self-collection. And so that's not exactly as simple as, never needing a provider collection, self-collection, because for many women, that means that they would have to come back to then get a pap smear collected, or they would be more likely to go on to colposcopy. But this idea that for people who don't want to come into the clinic or have barriers to speculum exams or pelvic exams, if they could self-collect a specimen, we could help, ease the burden for the 80 to 90% of people who could get screen negative from that and know that their follow-ups in a year or 5 years, and then focus the follow-up strategies on people who have abnormal results. So I think that is all relatively new, and there's a lot of questions about how the simplified strategy could meet the needs of underscreened women. So last January in 2024, they're using some of the moonshot funding. The National Cancer Institute launched this Last Mile initiative. So to address this remaining disparity of, 13,000 women getting cervical cancer who should have access to the screening and prevention tools for that. And we know that the women getting cervical cancer right now, they didn't have access to vaccines. So this is a failure of screening. So how can we get screening to those women? And so the goal was to use this idea of home-based self-testing to reach women where they are. And the initiative put forth 3 main objectives. One was to overcome the barrier of lack of FDA approval for a self-collection device. 2 is to get regulatory approvals for self-collection, and 3 is to I'm sorry, then the next one would, I'm sorry, the approach would be to get the regulatory approval and then to increase access and reduce the disparities, which would mean reducing incidence in underserved populations. So the 3 activities for that were really getting the regulatory approval for self-collection, and then carrying out some trials to look at self-collection devices, looking at the usability, acceptability, accuracy, and effectiveness of these devices, and then disseminating information on self-collection to change and inform clinical practice. So in May of this year, the FDA approved the first device that can be a primary device for home-based testing. And there are 2 testing kits now which are approved for self-testing, but this device can be used independently outside of the clinic, and is linked to a website or an app that can provide results directly to the patient and link her with follow-up steps. So that is an opportunity for home-based testing or self-testing, but there are also 2 just regular swabs that have been clinically validated to offer self-testing within a clinical setting. And then in this last, I guess, 2 months ago now, there were updated guidelines that were an addendum to the ASCCP, which is the Guideline Committee for Cervical Cancer Screening, which offered clear recommendations for what to do with self-testing. So how do you, self-testing results. So how do you evaluate results where it's just an HPV test and there's not also cells to look at? So we have that. And then the studies for of the various methods. So this home-based kit, the 2 swabs that are used in clinic, those are ongoing and those are nested. There's actually one at UNC, but they're nested across the country. So what's lacking in all of these, oops, I went just too fast, what are the implementation strategies? So I have been working in cervical cancer in East Africa for so long, but I'm an implementation scientist. So from the beginning, the area that I'm passionate about is how do you take these evidence-based interventions and actually understand how people who would benefit them want to and would be able to access them and use them. So what the NCI, the Last Mile Initiative, hasn't really engaged in yet are how do we understand how home-based self-testing would reach underscreened women and ensure appropriate follow-up. And this is important because in one study in the Netherlands showed that in the Netherlands is not an or underscreened country, that offering self-collection at the home, so mailing people test kits, simply pivoted people. So people who already were screening but were coming into the clinic, pivoted to doing self-tests. So it wasn't adding more people or reaching women who had previously been underscreened. So there needs to be some understanding of the population you're trying to reach and, to see how this new technology, which is being pushed as an effort to reach underserved populations, how it can actually reach them in a way that's effective and sustainable. So we applied for a pilot through the Duke Cancer Center to understand better how this could reach an underserved population within North Carolina. So working with SAICEP, we're hoping to develop a roadmap for implementation of the home-based HPV screening. And so in order to do that, we're going to try to understand beliefs related to cervical cancer and HPV, as well as barriers and facilitators to screening among people at risk for cervical cancer in the Lumbee tribe. And then we're going to try to understand the current pathways and the potential pathways, along with the facilitators and barriers to receiving follow-up care for positive screening results. So again, related to the work that I do in East Africa, we've really understood that, doing an HPV test, getting a woman to screen, and then getting that result is meaningless unless you can ensure that she understands what the results mean and she is able to understand what the next steps should be and have access to those next steps. And really all of the pieces that must be in place for her to access that next step of care, whether it's one visit or multiple visits after that. So really implementing home-based screening without a very well defined, an acceptable pathway for follow-up care would just be throwing away money. But also even worse is, saying, well, this population's been screened, so they meet this metric and we don't have to worry about it anymore. And so with the aims 1 and 2, we're hoping to develop a roadmap for implementation of how home-based screening could be, accessible and include linkage to appropriate follow-up care. And we're at the start of our project. So we're hoping to carry out these activities. We have developed a brief survey. So we really want to, survey about 250 women in the Lumbee tribe to understand their experience with screening and follow-up. And then it's maybe 10 simple questions about screening. We ask a question about vaccination, either for themselves or their kids. And we ask if they would like to be contacted to take part in an in-depth interview. So we'll be interviewing women and then key informants along the screening and treatment pathway. And we'll use those interviews to identify behavioral, financial, logistical, and stigma-related barriers to engagement with or completion of the cervical cancer screening cascade, and to help us understand the clinical pathway that would or could follow self-collected HPV testing offered in the home. And then we'll use a co-creation model to integrate the findings for people at risk for cervical cancer and develop a patient-centered model of a comprehensive cervical cancer prevention program for women in the Lumbee tribe. And so we've created these instruments. They're under review. Protocols have been submitted. We've actually gotten approval from Duke, and we're in the process of working with the Lumbee IRB. We're identifying interviewers for the IDIs and someone who can help us. The surveys would be done on tablets in health fairs or maybe talking circles or, community engagement events. And so we're planning to start those either this month or next month, and then start our recruitment of women for the IDIs in January and March, and then over the late spring, early summer, help develop this implementation strategy. And so that's all I have, and it would be really great, since we are in this beginning stage, if we could get some feedback or questions as we work on this project.
All right, and we are waiting for questions to come in. If you have one to submit, please go ahead and go to the link. That's polev.com/UNCLCN. And these are anonymous, and if we get any, we'll share those. While we are waiting to see if any questions come in, feel free to advance and go over the next few slides, and then I can let you know if any questions have come in.
If you'd like to learn more about SAICEP, please visit our website at www.saicep.org.
We do have a question that has just come in, and let me put it up on the screen. There you go.
Yeah, so I can address that. That's a great question. So the home test is a self-test, but right now the guidelines for screening will recommend that the primary recommendation is clinician collected specimens. And the reason for that is because it allows the collection of an HPV test, a swab for an HPV test, along with cells that could be read as a PAP test. So if one is abnormal, the second test is also available. And so the self-test is just a self-swab. There are three types of devices that could be used for the self-test. The home test is a swab. This is a CME, so I won't talk about the brand, but it's marketed and created in a way that includes instructions. The device has a plastic handle on it, so it is a little bit more comfortable for self-collection, and it has a tube that it can be mailed back in. So, the current self-collected swabs that are not validated for home test just go in a kit with a jar with fluid in it, and it needs to get processed at the lab. So it's not really something that would be amenable to getting mailed in, or, it would be very inconvenient for a community health worker to walk around with that. Which is not to say that there aren't going to be other products on the market besides the one that has been approved for home test. So home test is just another type of self-test, which has a specific collection kit.
All right, thank you. And it looks like we do have another, looks like more of a comment than a question, really reiterating what was said earlier. And I don't see any more questions at this time. Thank you.
Okay, our upcoming SAICEP webinar will be January 21st at 12 p.m. and it's featuring Dr. Rachel Dellinger as she discusses the North Carolina American Indian Adult Tobacco Survey Wave 1 findings. You can use the QR code provided to register for the webinar. We would also like to let everyone know that SAICEP has many more self-paced online webinars to view at learn.unclcn.org/SAICEP. We would like to say thank you to the University Cancer Research Fund, the UNC Lineberger Comprehensive Cancer Network, and the telehealth team.